So, welcome back everyone to another health talk. I've got with me today Dr. Coiner. Um, Dr. Coiner, at this point in time, I think you were just one of my favorite humans.
Oh,
I
great.
have very much
I'm
enjoyed
on the
spending
list.
the list. I have very much enjoyed spending time with you over the past few weeks. And when we first met, you told me that you were a lifelong learner. And
That
you
is
were
true.
not kidding
No,
because every time I spend time with you, I learn something new. You have your pilot's license,
I do.
you
Yep.
enjoy sailing,
I
you
like that
make
too.
you make caramels during the holidays.
I can't take full responsibility for that. I'm more of a participant in that. But yes, it is in the skill set.
So, I'm just really excited to do this with you, and we've
Yeah,
been on
it'll
the
be fun.
radio together,
Yes.
so
I'm
we're gonna
still
have fun.
pulling for a morning show, Maddie and Jack in the morning. It's
I
got a good ring to it.
I
Tell
know.
Mark to watch out.
Yeah. Yeah, Mark at High Country Radio, I hope you hear this someday.
Yeah.
Um, anyway, Dr. Coiner, I'll let you just briefly introduce yourself, and then
Sure.
because we are running behind, we have
Yeah.
so many questions and
We
things
got
to
lots of
cover.
questions. Yep.
So I'll let you briefly introduce yourself. Just
Sure.
who is Dr. Coiner? Let us know. And then I've got a whole bunch of questions printed out here.
Okay.
These are questions that we've had people submit. These are questions from your team. These are
Yep.
questions from my team and my friends.
Sure.
Um, this will be good. I also
Yeah.
wanted to give just some house rules here. So those that are watching, we cannot, Dr. Coiner and I cannot see you. Your cameras are turned off and you are permanently muted. So if you have questions or comments or feedback, please put that in the chat. If you have a question that you don't feel comfortable putting publicly in the chat, please know that you can privately chat me. I am monitoring the chat and I will respect your privacy. So if you have a question that you'd like to ask, please throw it in the chat. Okay, Dr. Coiner, now it's your turn. Let's go. Who
So,
are you?
Jack Coiner grew up in the Shenandoah Valley in Virginia, so mountain boy by nature. Did med school at Virginia Tech. I was the third class through the DO school at Virginia Tech. After going to Hampden Sydney all male school for undergrad, went to ECU for residency. Got robot trained there. Went home to Virginia. Practiced in my hometown for a while. Small town doctor, one of three guys, slugged it out in the trenches. Got recruited to go back to ECU, was in a big private practice group there. And then when you guys up in Boone bought the brand new shiny robot, had the opportunity to come up here. That's my specialty, is minimally invasive gynecologic surgery. So you had a new shiny robot and I can drive that. So I got to come up here. So this is my first GYN only position. So I'm doing just GYN. Um, Lots of surgeries, but also doing hormone replacements and infertility stuff. So full practice gynecology up here. My office is in Blowing Rock. Um, right now, operate at the hospital office in Blowing Rock. So married, two kids, 16-year-old, 14-year-old. So I am constantly driving from one event to another, into the hospital, into the office, and yep, been married 20 years. So um, got that kind of figured out. I don't know that you ever get really good at that, but I'm getting close. I've spent a lot of time with a lot of women hearing needs and questions. So I feel like I don't think any man can fully understand a woman, but I'm getting close to at least kind of understanding. So I'm happy to talk to y'all, answer some questions. A little bit nervous about where the questions are going to go because you never know. So
We're gonna have fun though.
let's do it.
No need to be nervous. Let's go ahead and jump right in. Like I said, because I've
Right.
got so many questions and I want to be able to
Hit me.
get to them all because I want to be able to cover everyone's questions. Okay.
Absolutely.
One question that we received during registration, and I may get the question messed up, but I'm going to read exactly as it was sent to me. Okay. This person said, is it safe for post HR and breast cancer patients to take hormones? What are your recommendations? I'm not exactly sure. Is post HR, is that post
Yeah. So with
hysterectomy?
so with the hormone receptor positive breast cancer, I think is what they're referring to. So if you have a breast cancer, you can have hormone receptor negative or positive breast cancers. With hormone receptor positive, that's what you hear is like an ER or a PR positive breast tumor. You would find that out on the pathology. You would have a significantly increased risk of recurrence if we did hormone replacement therapy.
Oh.
Most all of the therapies in HR positive breast cancers are targeted as anti hormones. So we want to get the hormones out of your body. I think in that situation, and I'm from Virginia, I got to keep things simple. So hormones, estrogen and progesterone in that situation, it's like putting fertilizer on the garden. Okay. And so the tomato plants get it and they love it. But if there's some small little tumor cells that have positive receptors, they will also get that hormone. And so then that hormone can help those cells more rapidly grow and divide. So I would strongly recommend against that if you have ERPR positive breast cancer. Going on hormones, kind of a no no. Um, Now, if it's hormone receptor negative, that's a whole different can of worms because then your tumor shouldn't be responsive to that. But still, like that would be a talk with the oncologist and your doctor. You'd have to weigh the risks and benefits of that. I would still probably encourage you to use some other medication that can help control the symptoms that you're having, whether that's vaginal dryness or hot flushes or sleeping instability. Like there are other ways we can try to solve that problem that hopefully would not increase your cancer recurrence risk. So that would involve quite a bit of talking. But just right off the bat, HR positive breast cancers, no, no on hormone replacement afterwards.
Boom. First
Uh,
question done. Okay. Going along the same lines as hormones, we had a few questions about hormones. And
yep,
this person said, are hormone imbalances real? I hear
sure.
so many people talking about this, dot, dot, dot.
Yeah. Hormones are like the new jam. I think a lot of that came from Oprah
Yeah.
and appreciate her at least starting the dialogue because I think a lot of women, it used to be a suffer in silence kind of situation where it's like, yes, you're going through the transition. Don't complain. You've got other responsibilities as the wife in the household, like move on with life.
Mhm.
So at least we're talking about it.
Yeah.
Hormone imbalances, all hormones are is basically a cellular signal to another cell that it wants something to be done. Okay. So if we can use thyroid stimulating hormone as an example. So TSH, thyroid stimulating hormone, is a hormone that signals your thyroid gland to make more thyroid hormone. Okay.
Okay.
They usually have a feedback loop. So if your thyroid is doing a good job in making T3, T4 thyroid hormone, your brain sees that and it's like, hey, good job. You're doing what I need you to do. And so it kind of makes a steady state. Okay. Hormone imbalances will come when it's not getting the response that it's expecting. So we can stick with thyroid or we can switch to ovaries. It's more in my wheelhouse. But if your ovaries start to fail, either menopausally or premature ovarian failure, your brain is going to be screaming at your ovaries to try to work. Okay.
Mhm.
It's not getting that estrogen and progesterone feedback saying that the girls are doing their job. And so your brain is going to keep ramping that signal up as much as it can. So, from a hormone imbalance standpoint, when we do lab values, we can see that your follicle stimulating hormone, or how hard your brain is yelling at your ovaries to work, is very elevated. And we know then that the girls aren't doing their job because it's like that shouldn't be that high in that situation if they were actually listening.
Wow.
So,
That's
yes, hormone imbalances are real. Yes, they are
okay.
a thing. We use them mainly as markers on like, is the organ that we're hoping is working, is it responding? Because we see a lot of sending markers where it's like, hey, I'm asking you to do something. Am I getting the result that I want, or am I having to ask a lot?
Mhm.
Likewise, if your thyroid is making a ton of thyroid hormone because there's a dysfunction with it, your brain then would turn your TSH down because it's like, whoa, 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 I'm getting enough of that. Like you can slow down on how much you're making. And so we would see that as an artificially low TS, or not artificially, just a suppressed TSH level. And then we know that you're hypothyroid because your thyroid is basically running rapidly away with your body. So, yes, hormone imbalances are a thing.
Are real. Okay.
Yes.
Okay. We've got some questions coming in on the chat
Okay.
here.
All right.
So I'm gonna kind of jump to those, and then if we don't get
Yeah, that's
questions,
fine.
I'll kind of jump back to my
Do it.
paper. And also, FYI, we do not have to rush. If we don't get to all
Okay.
of these, that just means
Yeah,
we
yeah.
can have a part two, right?
Part two. Yeah, let's do it.
Okay.
All the best movies have redos, right?
Yes, we can have a part two. We can have a part three.
Yeah.
Okay, so this question I think kind of can go along the lines of when we're talking about hormones and stuff.
Sure.
So this individual said, for someone with PCOS,
Yep.
is an endocrinologist or a GYN the most appropriate provider to see to regard management of that condition?
Sure. I would say that I would start solid, like that's a crossover area. Okay. So PCOS You can see an endocrinologist for that. You can see a reproductive endocrinologist, which is a subspecialist just in reproductive health.
Mhm.
Most of the time, if it's just a run of the mill PCOS, gynecology should be all over that. Okay.
Okay.
Um, if we want to talk a little bit about PCOS, so PCOS is a dysfunction of the ovary where it makes too much testosterone. The middle part makes more testosterone. It inhibits ovulation. So your brain is going to be yelling at the girls to make an egg. Right as that egg develops, the testosterone's like, no, 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 you don't get to do that. And it arrests before it releases. And so with PCOS, you have periods that don't occur as frequently. So there are periods that are more spaced out. You have some signs of increased androgen or male factor hormone. So if you can grow a cool mustache or you have a little bit of fur on your forearms, um, that can be a sign. And then we do an ultrasound and we look at your ovaries and they look like chocolate chip cookies. You're
Wow.
the in the textbook they call it string of pearls, but as a big kid it looks like a chocolate chip cookie to me. And what you're seeing is the polycystic nature of that are the small little cysts in the ovaries. They're just failed ovulation events. So
Wow.
when you're in make a baby mode, we focus more on getting your ovaries to actually develop an egg.
Mhm.
90+% of the time I can do that just by using a medicine like Clomid or Femara, and we kind of follow along. We just increase the signal to your ovaries. So that FSH that I was talking about, we try to bump that level up so the girls actually listen. And when I'm saying girls, I'm talking about the ovaries.
Yes. Yes.
So um, when you're in not have a baby mode, then it's mainly just regulation of your period because your periods can be heavy when they do happen and they're happening infrequently.
Yeah.
We don't want that lining to grow and grow and grow and never shed because it can lead to like precancer or malignancy. And
Wow.
so in that phase, it's usually just something like birth control that helps regulate your menstrual cycle. And then very quickly afterwards, we're like, hey, let's switch gears. We'll go on Clomid or Femara and try to do that.
Okay. Now, if someone is diagnosed with PCOS, is that something you have for your whole life, or is it something that can ebb and
Generally
flow?
can. So we're going off the reservation, Maddie. It didn't take long. So this is we're getting in Dr. Coiner's brain now, not in the textbook. Okay.
I love
So
it.
Dr. Coiner thinks that there's probably two types of PCOS. Okay. And not to be offensive, but we see our little like hairy girls come in. Okay. So they're like thin as a rail and they have a full beard. They have got forearms that look like mine.
Oh,
That, in my opinion, is a primary ovarian dysfunction. So her ovary is the problem.
okay.
Okay. Now, my sweet heavyset patients, they come in. All right. When you have excess fat cells, you make more estrogen. The fat can turn other hormones into estrogen. Okay. What we were just talking about, your brain sees that increased estrogen
Mhm.
and it's like, good job, ladies. Take the rest of the month off. You've already made an egg, even though there's no egg. Okay.
Okay.
So if I do an ultrasound on both of those patients, it's kind of like type 1 diabetes and type 2 diabetes, where it's like, okay, one is a problem with the organ, the other one it is the organ isn't working, but it's something that we can correct. So with the type 1ers, there's nothing we can do. That's how her ovary works. We need medications to ovulate or birth control to regulate. My heavier set patients, their ultrasounds look exactly the same. We both have chocolate chip ovaries, okay? But if she loses weight, that estrogen level comes down, then her ovarian function comes right back. And then it's like, hey, cool, now you can get pregnant all on your own. You don't even need my help to be involved in that. And
Mhm.
so that's kind of like the two different like types of PCOS. Again, not going to see that in the textbook. That's between us, but I think that is how that works.
Okay. Thank you. Let's
Yep.
see. We've got a few other questions that have been submitted here, and I want to make sure
Yep.
I get to all of them.
Yep.
This individual said, you may not know the answer to this one. I don't know. We'll find out.
Okay.
Um,
I'll make
I,
something up if I don't know the answer.
okay. And then we won't know.
Yeah.
Okay. She said, I wanted to see if UNC Health Appalachian is considering expanding pain management options for IUD insertion.
Yeah. So IUD insertion, historically, like when it first started, it was very much on the like suck it up buttercup kind of thing.
Mhm.
They came out with a study not too long ago where they did pain scores. So for a nulliparous female, somebody who has never had a baby, the pain score for an IUD insertion was the same as a labor contraction.
Oh my
And
God.
that was kind of like, oh, okay, cool. Maybe this is actually a legit thing. So most of the time now, if I'm going to do an IUD insertion, I'll pre-medicate so we can give medicine that you use the night before your appointment that kind of softens your cervix up. So hopefully the IUD goes in easier. There's some numbing creams, kind of like Oragel, that you can use for the cervix to kind of decrease that sensitivity.
Mhm.
Um, Sometimes we'll put them in with more like under anesthetic, but that you most of the time, if we pre-medicate, the goal is you never want a patient leaving the office with PTSD. Okay. So
Yeah.
I don't want to struggle, especially in the office kind of guy. So if it does not go easy, it just does not go.
Mhm.
I hear horror stories all the time about IUD insertions, but with if if it is that hard to put it in, it is very concerning that it is not going in the correct location. And so if we've pre-medicated and we've done all this stuff, I'll very quickly kind of pivot to ultrasound and put it in under ultrasound guidance to make sure we're in the right location.
Mhm.
Or if we need to like do more dilation, that's when you need like more anesthetic. So
Okay.
hopefully there is more recognition that like putting an IUD in on a sweet 18-year-old
Mhm.
is definitely a legit experience for her.
Mhm.
And there should be some validation of like, yeah, there are things we can do to try to make that more comfortable for her.
Okay. Awesome. I hope that answered that individual's question. Um, okay, and then we have another question here in the chat, which we will get to towards the end. This is a question
Okay.
that says, "Are you taking new patients, and how do we make an appointment?" But we
All
can
right.
cover it real quick right now. Yes, you're
Yeah.
taking new patients.
Always taking new patients. Yeah. So far, taking new patients. Love to see you. Happy to talk, get to know everybody. That's my favorite part about this job is just getting to know people and interacting with them on a daily basis. Um, Having a relationship, especially with a gynecologist, is important because we're talking about stuff that you don't normally talk about. And so having that trust factor of like, okay, we're going to lay it all out here on the table and we're going to talk through it, I think puts everybody in a more comfortable situation and puts you in a position to actually get some stuff done and get better because you're not having to like hide it or feel judged or whatever.
Yeah. Okay. That I think I've covered all the questions that people have just submitted here, but
Okay.
please continue to submit questions, everybody. We'll get to
Yep.
them the best we can. So I'm
Yep.
gonna go down my little list here that I've
Okay.
got.
Come on.
Okay, this question is, should I be worried if I have low libido? And then there's a kind of a branch off. Someone else had another question that I kind of added to this question.
Okay.
Can birth control affect your libido?
Absolutely. So, the libido question I get all day, every day.
Yeah.
Okay. Y'all, women, okay, are
Mhm.
much more complicated than men. Okay.
Mhm.
As a man, will freely admit to that. Okay.
Yeah.
If a
Okay.
man can get aroused, he will have sex. And we have pills for that. Okay.
Mhm. Okay.
You guys use your brain and vagina at the same time. Okay. Guys, jokingly, only have enough blood to run one or the other. Okay. And so it is much more difficult for the female libido. Okay. There is a lot that weighs into that. Okay.
Yeah.
Um, I encourage folks. Sorry, we're bing bonging around. This is a topic. We could spend the next 2 hours talking about just this. So I'm trying to
I am
formulate a
so
response that
excited. We're
makes
gonna
sense.
do a part two. We're going to do
Okay,
a
we
part
can do
two.
it. We can do a part two. So the generally, like that's where we bring in some mental health component too. Okay. There women I have found put a lot of pressure on themselves off expectations that the man may be putting on them or it may be perceived. Okay. So critically important that we have open lines of communication. If he's coming at you and he's like, "Hey baby, I need it once a day and twice on Sunday,"
Okay.
then you're like, "Yeah, ha, ha, okay, dream on." Um, so that's, but he might be totally happy with like, "Hey, on my birthday and maybe Easter, great, that's awesome." And so then you're putting all the pressure on yourself of like, "Oh my gosh, I'm not meeting his needs," and he's like, "I'd rather work on the bass boat and go hunting. I don't really need it." So super important open lines of communication. Um, I usually coach people that there's like two ways to kind of handle that, the
Mhm.
sexy way and the unsexy way. Okay. The
Okay.
sexy way, he has to warm the car up before he takes it around the block. Okay.
Mhm.
So there's got to be some pre activities to kind of get that going, even going out to dinner. Hey, honey, we got a babysitter, we got a bottle of wine, like decrease your mental stress around that
Yeah.
activity. And so then the activity isn't the focus of the relationship. It's a sequelae of a healthy relationship. It's like, hey, everything's functioning awesome. Great. Here we go. So the unsexy way, schedule it.
Yeah.
Okay. Put it on the calendar. I've got friends who have Sunday fun day. I have friends who have no pants Monday. Just come up with a cute name and put it on the calendar. What
I
that
love
does,
that.
even if you're dreading it, okay, it's like, oh my gosh, it's Tuesday again already. physiologically you'll be more responsive to that, okay? Because it's like, hey, it's Tuesday. Even if it's like, oh my gosh, it's Tuesday, it's still like, hey, here comes Tuesday, here comes Tuesday, this is the thing that we're going to do.
Yeah.
And then it puts some value on it. It also gets him off your back on Thursday when he rolls over and he's like, hey, look at this, and you're like, oh my gosh, put it away, I'm going to work. Okay, so that is kind of how we process through that. That's where like a marriage and family therapist really like comes in, because they're usually, not always, but we have to unpack, like there can be emotional trauma from the past, abusive relationships, poor body image, like there is so much that goes into that.
Right.
That is where it is super important that you have a good trusted like mental health person to be like, hey, let's process through
Yeah.
some of that. Now,
Yeah.
rubber meets the road stuff, like, hey, I'm dry, hey, does my birth control decrease my libido? GYN's got you all day, but the ability to sit down and like, hey, let's talk, for an hour every Tuesday for the next 6 months and process
Yeah.
through this, usually in the medical community is like, yeah, we got to get off the bus there.
Yeah.
Not that we wouldn't want to, just, we're just not set up like that. So I'm talking a lot, but birth control will definitely decrease your libido depending on what type of birth control it is. All
Mhm.
right. Without getting in the weeds too much, when you're on an estrogen containing birth control, estrogen makes something called sex hormone binding globulin.
Mhm.
Okay. It can decrease your free testosterone. So, free testosterone is what can make you have a mustache, but it's also what makes your libido go up. That's why
Mhm.
we were talking about the difference between guys and girls. So,
Right.
y'all have a little bit of testosterone. We got a lot of bit of testosterone. When you're taking the birth control pill, sex hormone binding globulin will bind free testosterone.
Mhm.
So your testosterone level doesn't change in your body, but the hormone that's actually hitting receptors and making things happen
Mhm.
decreases. Okay. And some women are more sensitive to that than others. And so if the volume was already on a 3 and we turn it down to a 1, that can absolutely be a thing.
Got it. Okay.
So in that situation, we switch birth controls around, we decrease your estrogen levels, and we try like, hey, let's do a progesterone only form of birth control. Maybe that won't affect it as much, and kind of go from there.
Yeah. Well, I really like that you started this question with that you get this question all the time. So,
Dude,
all the ladies listening, please
yeah,
feel comfortable to talk to your
yeah,
GYN about this because apparently they get the
multiple times a
question
day,
all the time.
all the time.
Yeah. Okay. Next one.
All right,
Ready?
ready,
Okay.
I guess.
Can you get pregnant while breastfeeding? I think this
Okay,
is one that we have all witnessed someone that got
sure,
pregnant while breastfeeding.
absolutely, you can. Yeah,
Um, and then another question was similar that I kind of added to this one. Can you still get pregnant during perimenopause?
mhm, okay. So let's unpack the first one. So when you're breastfeeding, exclusively breastfeeding, you're increasing levels of prolactin, going back to hormones. So that is a hormone which will feed back to your brain and it will turn the girls off because it's like, hey, ladies, we already have a baby. We don't need to make another one.
Mhm.
Now, if you go more than 4 hours without nursing, which happens pretty quickly, that prolactin level will drop down enough that your brain's like, hey, you know what would be cool? Let's make another one.
Yep.
You ovulate before you menstruate. Okay. And so you can't wait to be like, oh, once my period comes back, I'll start some form of contraception. You can get pregnant immediately after having a baby, especially if you're not breastfeeding. Like within the first 6 weeks, like you can get pregnant before you even have a period. Okay.
Oof.
Um, Now, what kind of lines that guy's using to have sex in that first 6 week window, like bless his heart, like write those down in the comments if you've got those. But yeah, uh, so, yes, you need to use backup contraception. A
Hmm.
lot of times, too, this is just Coiner talking. The mini pill is progesterone only. It's safe for breastfeeding, and we use that a lot. It is super important if it's going to be effective that you take it at the same time every day.
Okay.
And you just have a little screaming infant there that's going to keep you from doing anything at the same time of every day. So it can be as low as like 87% effective. And so if you're nursing and taking the mini pill, I would still make him wear a raincoat if you're going to go outside type situation, just to be super safe because nobody wants to be stacking babies on babies.
Yeah. Okay. Second part of the question was perimenopause. Can you get
Yeah,
crushed or can you
perimenopause.
get
So
pregnant? Yeah.
here's the thing: as long as you're ovulating, you can still get a fertilized egg. Okay.
Okay.
As you age, it becomes increasingly less likely that you're ovulatory,
Mhm.
but it is also very hard to stay pregnant. Okay. If you look at a graph, your fertility rate From around 35 to 40 kind of trickles down. 40 is the fertility cliff. Okay. So if you're hearing your egg timer, 40, if you look graphically, is where it's like, yee, it like free falls down. That is not just the getting pregnant, the miscarriage rate climbs exponentially at that point. And so, yes, you can still fertilize an egg, but the actual, like, oh, I'm carrying a pregnancy gets very unlikely, especially from your mid 40s on.
Okay.
No, that's not saying that you don't need something to, and you'll hear horror stories or, hear Facebook posts of like, hey, I don't know. I've taken care of a patient before. She was 52 and pregnant, and she swore up and down that she got spontaneously pregnant. It was actually a donor egg, but we won't blow up her spot. But that is very unlikely to happen. Okay. Usually around 47 is kind of where the line crosses that, like, how good any of my birth controls are at keeping you from getting pregnant is the same as how good you are at getting pregnant if you're not on anything and you're just 47 years old.
Yeah. Crazy. Okay.
Yep.
Going along the same line, we just had a question submitted. At what age are most women completely through menopause?
So average age of menopause is 51.
Okay.
Okay. But it's a bell curve. So for everybody that somebody gets off the bus at 48, somebody's going to ride the bus until 54 or 55. So menopause diagnosis is no periods for a full year. Okay. So if you make
Okay.
it a year with no menstruation, that is menopause. Okay.
Okay.
Now, there are weird things like premature ovarian failure where it's like, I went through the change at 40, and it's like, okay, you need to come see me for that because we need to look at your hormones to see if it's like, really, did the girls stop working or is there something else going on? Because we don't want you to turn into a sweet little old lady at 36 because you thought you went through menopause early. But 51 average age. Now, duration of symptoms, 2 to 10 years. They came out with a study that published that, and I was like, hey, thanks for that study. I could have told you that without you spending all the money on research. Some women sail through the change, and it's like a beautiful phase of life, like nothing ever happened. And some go out fighting and clawing. And thankfully, we have hormone replacement to help with that if we need to. We just have to meet and talk about the risk benefits. Not, hormones are not right for everybody, like we were just talking about, but it can help a lot of women just ease through that transition.
Okay. Let's see. We had another question submitted, and we're gonna kind of jump back a topic here.
Okay.
Is it possible that low libido is part of a hormonal imbalance? If so, are there natural supplements or ways to increase libido? Other than
Sure.
some of the things that you shared with us
Yeah,
before
yeah, yeah, yeah.
about
So we talked about
scheduling.
the tried and true. So here's Dr. Coiner's trying not to offend anybody's thoughts on natural supplements.
Okay.
Natural supplements are not regulated by the FDA.
True.
Okay.
Hmm.
You are totally trusting the company that made it to put in it what they said they were going to put in it. Okay. My concern with that is if you're taking something like soy, we know has estrogens in it. All right. Soy plant A may have this much estrogen, soy plant B may have this much estrogen. Okay.
Yeah.
Now they're mixing that in batches, but you don't know how much specifically you're getting. Okay.
Okay.
When we do hormone replacement that the drug companies are actually making, they
Yeah.
have a margin of error that it's like, hey, it's within this tight range. So I know realistically, I'm within 20%, I'm giving you how much estrogen I actually think you're getting. Now,
Yeah.
bioidentical hormones. We're stepping on the third rail. This is when, like, if you see people just start clicking off and clicking off.
Okay. Oh
This is
no.
me. This is not everybody. Hormones by nature is a chemical compound that looks the same. Okay.
Okay.
Whether or not it came from a plant or from a pregnant horse, and this sounds weird, but Premarin is an estrogen. Okay. Premarin is short for pregnant mare urine. Crazy,
Hmm.
but they get the estrogen from getting pee samples from pregnant horses.
What?
Crazy. Okay. But to your body, the estrogen that came from the soy plant
Mhm.
is the estrogen that came from that horse. Okay. So if we're bioidenticaling to your body, bioidentical is like it is the hormone or it's not the hormone.
Yeah.
The form really doesn't matter. The supplement thing that drives me a little crazy is just the, like, how much is actually in it? How much are you getting? And
Right.
you can be throwing off your hormones because we talked about all those feedback loops and all that stuff. So if you
Right.
truly have a dysfunction and you're treating it, yes, the supplements may help with that 100%. Okay. But when we don't know exactly how much you're getting on feedback loops, you could be throwing off other stuff.
Mhm.
I jokingly say that a lot of those folks that use more natural supplements keep me in business because it kind of messes with things. And then they come in and they're like, "Hey, I'm bleeding weird. I'm still having these symptoms." And it's like, "Okay, cool. What are we ingesting? Like, are we making this problem worse?" Okay.
Right.
Now, for some people that are not having like severe like hormonal imbalances, some supplementation may work totally fine. If it works for you, do it. I'm enough of a libertarian that I'm not going to be like, no, you have to do it my way. I'm like, girl, if you want to stay crunchy granola, rock it out. I'll provide some guidance. You do you, and we'll try to make it better. But I don't like seeing people sell snake oil where it's like, no, 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 this is derived from the Peruvian soy plant. I climbed to the top of the mountain to get it myself. It's going to treat you better than the evil drug company's drug. That's where I get off the bus a little bit.
Got it. Okay, makes sense.
Yep.
We're getting questions back to back
Okay.
on here, and
Okay.
I
Okay.
love it.
All
Okay.
right.
This person said, "What is the best treatment for ovarian cysts?"
Okay. So, ovarian cyst, there are multiple different types. Most of the cysts, if we're just playing common things being common,
Mhm.
follicular cysts.
Okay.
It's a failed ovulation. So your brain was like, hey, ladies, let's make a baby, stimulates the girls. They start to grow and respond with that egg.
Mhm.
The egg is what sends the launch signal when it's like, hey, I'm ready. Let's pop and float out. If the egg's a dud, your brain's like, go, buddy, go. You can do it. Go, 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 go. And it starts growing that cyst and it fails to pop and float out. Okay. Then you get hung up with a follicular cyst.
Yeah.
They will almost always go away by themselves. Okay. You'll have some pain. You think you have appendicitis and it's like, I'm
Yeah.
going to the ER and they're like, Daryl, you just got a cyst.
Yeah.
Follicular cyst will follow up, but almost always they go away. There's no treatment to make that go away other than surgically like popping it or draining it
Yeah.
or removing the cyst. We don't do that usually unless it gets above 6 centimeters. So like the size of a baseball is when I'm
Whoa.
like, hey girl, we got to go to the OR because the risk we don't want it to get so big that it twists on the blood supply because then you can
Yeah.
lose your ovary.
Wow.
That is very rare that they get that large. Most of the time, they'll stay in the 3 or 4 centimeter range. They'll either pop or they'll go away on their own.
Mhm.
The treatment for ovarian cysts is to prevent the next one. Okay.
Okay.
If you want to make my job super dumbed down, I have two hammers. Okay. I
Okay.
have a birth control hammer and I have a surgery hammer. All right.
Mhm.
So the treatment of that in that situation, if you come in, you're 24, you have an ovarian cyst, it's like, hey, let's follow up in 4 to 6 weeks to make sure it goes away. Put you on birth control to suppress the girls. All birth control does is fools your brain into thinking there's already an egg developed. And so it's like, good job, ladies, take the rest of the month off. That's all we're doing. Okay.
Right.
And so it will prevent that from happening again. Some women are much more common at forming cysts than others. And so that's something we can talk about. And some forms of birth control are better at that than others. Like an IUD, if you're a cyst former, in my opinion, is not a great choice.
Yeah.
It only keeps you from ovulating about half the time. And we don't
Mhm.
know which half. And so it may help some, but it may actually make you form more cysts. So that's something you need to talk to your GYN about, just about, hey, is this really the best bet, for me?
Right. We got another question about
All right.
IUD, so I'm gonna kind of like
Okay.
jump. That's a perfect segue here.
Cool.
This person said, "I've heard that the longer you have an IUD, the harder it is to conceive once you have it removed. Is that true?"
Fake news.
Fake
So
news.
so here we go. IUD has most of them. There's two main types. There's progesterone containing IUDs and copper IUDs.
Okay.
Copper IUDs do not inhibit ovulation at all. They inhibit either fertilization or implantation. So the copper inside your uterus just makes it kind of inflamed. It's not conducive for a pregnancy and it keeps it from happening. They last at least 10 years after they're placed. They probably last a lot longer, but I didn't tell you that. So progesterone IUDs, okay, it will last. When they first came out, they were 5 years. Now we're up to 8. It's been kind of an arms race between the different companies on how long they last. It can stay in there. It only inhibiting your ovulation like half the time.
Mhm.
I usually will tell folks it is immediately reversible. So when we pull the IUD, you can get pregnant that night because if you're ready to ovulate and that IUD is not blocking it, we pull the IUD out, we pulled the goalie, You play hockey, you can get scored on. So that is not a like, hey, let's stop using it like Depo. Takes a long time to wash out.
Yeah.
That's one where it's like, hey, if you want to get pregnant in November, let's stop in March, make sure we get back right. With
Yeah.
an IUD, you could get pregnant right away, but it usually is not going to last more than that next cycle before you're right back on the bus, which is why we use them so much, because they're pretty much immediately reversible. If you don't like how you feel, we just pull it out. You just have to pay all your dues on the front end with getting an IUD, but then you don't have to worry about it. So
Yeah.
that's the trade-off.
Awesome. We've got a few more questions here. We've got about 10 minutes left. We will
All right.
definitely have to have a part two because we didn't get
Okay, we
to.
can do it. Yeah, we didn't
Yeah.
even get to the list. Yeah.
I know, but that's great. I love it. I'm glad that
All right.
people are engaged.
Yeah.
Okay, this person said, my mother died of breast cancer. What is the percentage my sister and I will get it?
So, in that situation, we are getting pretty fancy now at doing genetic testing to see your predisposition for breast cancer. Okay. We would need to know that piece of information for me to give her a specific not wrist,
All right.
risk. Here we go. Make an appointment, come in and see me. We'll talk genetic tree, like who had it, how old were they when they got diagnosed.
Mhm.
Most of the time now we're doing breast cancer gene studies. Okay. We used to just know BRCA, BRCA 1 and 2 were like the two things we knew. We're up to like 10 or 12 now that we can test for. Some of them we have really good data on, like, oh, this is how we need to handle this because you're predisposed for getting breast cancer.
Mhm.
Like BRCA 1 and 2, we've got a lot of data on how we need to treat that. Okay.
Yeah.
Most breast cancers are spontaneous. This is terrifying, but it's not a family like, oh, mom got it, so I'm going to get it type situation.
Yeah.
If we know you're positive for the gene, that's when we talk like, hey, you need to get MRIs on 6-month intervals. Do you go ahead and get a prophylactic mastectomy? Like, we need to know the genetic predisposition. Lifetime risk for breast cancer is about 1 in 8, which is terrifyingly high. So
Yeah.
you will know multiple women in your circle that get diagnosed with breast cancer. So just playing statistics, mom's breast cancer that she was talking about was probably just a spontaneous thing that happened.
Yeah.
But to verify that, usually with insurance companies, they'll pay for us to get testing if you're the one that has breast cancer. In that situation where mom already passed away from breast cancer, we'd sit down, look at that, and I would, if it was my wife, go ahead and get the testing just so we know what to do.
Yeah.
Because then, especially like BRCA2, for example, it gives you a 20% lifetime risk of getting ovarian cancer too.
Mhm.
And so that is, we are not very good at diagnosing that. We usually catch it really late. And so that's something that we sit down and we talk about, like, hey, you're BRCA2 positive. You're done having babies. Like, at what point do we take your ovaries out? Because we're terrible at diagnosing this before it gets advanced. And that's something you need to sit down and talk. We can get all the numbers she wants. We just have to do some blood work to see genetics wise if it's just a baseline risk or it's an
Yeah.
increased risk.
Yeah. Awesome.
For her, if mom got, so just from a screening thing, just real quick while I got her on there, this is for every woman out there. If you have a first degree relative that got breast cancer, you should start getting mammograms 10 years before she was diagnosed. So if mom got breast
Mhm.
cancer at 46, you should start getting breast cancer screening at 36. So it does. So we start looking early just in case it does, increase prevalence in your family.
Right. Wow. We've got another question here about
All right.
cancer. This is about ovarian cancer.
Yep.
Are there any new updates or testing options for ovarian cancer? I've heard, all I've heard of is the CA 125,
125. Yep.
125 blood
Yep.
test, but that isn't very reliable.
Correct. She's exactly right. We have, I will freely admit that we stink at diagnosing ovarian cancer. Okay. And the reason being is because the symptoms with ovarian cancer are the same symptoms that you ate too much cheesecake at dinner last night. So it's like, hey, I feel bloated. And it's like, okay, cool. That's probably gas, but it could also be ovarian cancer. And so trying to wade through that, we have to have a high degree of suspicion. Ovarian cancer usually happens later in life. Okay. So younger folks, you're usually in a safer window. We have looked at all kinds of different strategies where it's like, hey, let's do screening ultrasounds. Let's do screening ultrasounds in CA 125s. What if we did CT scans on things? We stink and none of it is good at catching it. So, really, we have to have a high degree of suspicion. We have to do early imaging. And if we see a complex mass, generally what happens, so we do an ultrasound, we see a cyst that looks weird, not like a follicular cyst we were just talking about, but it's got like, different little cysts inside it. It's more complicated. Then I get tumor markers, and then we talk about like, hey, is it worth going in there to take it out so we can actually see what it is, with the pathologist telling us, what's going on. So,
Yeah.
um, ovarian cancer, terrifying,
Yeah.
like getting hit by lightning. Okay, doesn't happen a whole lot, but tends to be bad when it happens.
Wow.
Yeah, we're doing some of the newer stuff with the BRCA stuff.
Yeah.
So we're doing more prophylactic removal of things.
Mhm.
And a lot of the research now, what we used to call ovarian cancer, we're thinking may start from your fallopian tube. So, um, if we do tubal, so you're like, hey, I'm done having babies. If we take your tube totally out, we decrease your rate of ovarian cancer by close to 87%. And
Wow.
it's like, okay, well, that's a huge difference. And so your ovary here, your fallopian tube kind of sits like this. The fallopian tube has a fimbriated end. So it gently like wisps the egg into the tubal opening, but those cell types on the fimbriated end they're kind of like a weird cell type. And so women like Angelina Jolie is one we throw out there a lot. She found out she was BRCA positive, had prophylactic surgeries done. When we're doing these prophylactic tubals, they're finding these premature ovarian cancers, but they're on the tube side, not the ovary side. And
Yeah.
so they're directing focus on like, hey, maybe ovarian cancer is actually fallopian tube cancer, but it just was guilty by association. So
Yeah.
more to come on that. But
Okay. Well, thank you. I
yeah,
think that was our last question. We're at
okay,
12:43 right now, and I want to be
okay,
respectful of
cool,
people's time.
yeah,
I'm going to share my screen really quick.
okay,
Maybe we're getting
maybe.
there. Share my screen. This has Dr. Coiner's information. Well, it says you're about to share. Okay.
Hey,
Hopefully I'm sharing it. Do you see your face, Dr. Coiner?
I see my face.
Okay.
Look at that guy.
And this QR code will take you to Chestnut Ridge's webpage. But I hope that you all were able, one, to learn something, but I also hope that you feel empowered now to go have these conversations. I